Welcome to today's talk, Rosai-Dorfman Disease from Rare to Understood, with our special guest, Dr. Gaurav Goyal, University of Alabama at Birmingham. So just a quick housekeeping, this meeting is for informational purposes only. Before making any changes to your healthcare, please speak with your medical team about your specific circumstances. We will be answering questions today. We may not be able to answer all, so if there are additional questions, we'll follow up wherever possible, or you can email any of us who are here presenting on the talk today, and we can follow up with responses to your questions. And finally, the webinar is being recorded and will be sent out as soon as possible, hosted on YouTube, and with each of the organizations that are here today co-collaborating for this talk. So just briefly, how to use the platform. So you'll see that toward the bottom of your screen, there's an option to switch between languages. So you can choose the language that you'd like to listen to the talk in for audio transcription. And then you can also choose the language that you'd like to see captions on the left side of your screen. So you can go ahead and select the language for your audio and captions if you need that. Our speaker today will be presenting in English. On the right-hand side, you'll be able to message today. So if you have questions throughout the talk, you can put that into the messages, and we'll be taking time to go through those. After the presentation, there will be a dedicated Q&A, so if you'd like to save your questions for that time, you can put them into the messages as we head toward the later part of the talk. But if you want to put it in while you're thinking of it, go for it, and we will be sure to go back and look for those. Your hosts today are the Histiocytosis Association, dedicated to raising awareness and emotional support about histiocytic disorders, funding research leading to better treatments and a cure. And Peter is in the background today, so Diana Fournier here taking over for Peter. We also have with us Claudio Di Girolamo, the president of the Histiocytosis Association of Canada, who's dedicated to helping Canadians affected by all types of histiocytosis. And then I'm going to pass to Belinda to present the next two of your hosts.
Hello, everyone. Thank you for joining us today. I'm Belinda Cobb, the ECD Global Alliance Patient Navigator. Our organization is dedicated to supporting Erdheim-Chester disease patients, their families, and the physicians who treat or research ECD. In addition to patient support, we fund research, raise awareness, provide education, and connect the community members worldwide. We thank you for joining us today for Rosai-Dorfman Disease from Rare to Understood. And Deanna, I'm sorry, I don't see the slide for Fernando.
No problem. So also collaborating today as a host is the OR Association based in Barcelona, Spain. And Fernando Goetz is joining us. He's the president of the OR Association, which he founded for his son in 2013. And it stemmed from volunteering amongst a group of friends and family after the diagnosis. And OR serves Spain and other Latin American countries now, such as Argentina and beyond.
Sorry about that. Slight glitch on our end, but I'm just getting the slideshow back up. So here's the full screen of the instructions again, by the way. I'm not sure if it showed before, but that was just one of the things we were trying to work out, and it's been a little glitchy today, the platform, but please bear with us. I would just take a screenshot of this if you feel you're going to have a hard time, and then we'll continue on with the slides. I'll just give everyone a moment so you could do that. Okay. Now I'm going to go back to the main slide. I just wanted to introduce Dr. Goyal, an assistant professor at University of Alabama at Birmingham. And he, of course, is going to be talking today about Rosai-Dorfman. And I will leave that up to him I'll let him change over to his slides. Please give us a moment. Over to you, Gaurav.
All right, I'm gonna try to make sure that you all can see my screen, especially when I do full screen. So Peter, if you can let me know if you can see my full screen or the presenter.
All good? Yep.
Okay, well, hi everyone. I am very pleased to be with you all to discuss this important disease, which has been poorly understood for a while, but we have learned a lot about this disease in the last, I would say, 5 to 10 years. And I am happy to be discussing some of those updates with you all. And my talk is supposed to last approximately 30 minutes. We'll try to leave ample time for any questions and answers or that you might have. So we will review some cases from my clinic. We'll review the classification of histiocytic disorders. We'll take a look at what are the features of these diseases, where do they present most commonly and rarely, and what are the mutational features, what are the molecular features. We'll then turn over to talk about the diagnostic tests, workup that is needed for a new diagnosis, treatment options, then go back to the cases for conclusion, and then chat a little bit about the future directions or areas of unmet need. So the first case is a 7-year-old boy in 2016 developed sinus infection-like symptoms. Then also had lymph node enlargement in the neck, which was biopsied and found to have Rosai-Dorfman disease. Started on prednisone over a long period of time, several months, with a partial response, meaning there was some shrinkage in all the lymph nodes, but did not go away completely. When the steroid was stopped, the disease came back, received steroids again. Then 2020 had another sinusitis-like episode, had a surgery of the sinus tissue that showed persistent Rosai-Dorfman disease. And here is just a PET scan on the right showing the uptake in the lymph nodes in the neck and the chest, just two different images. Second case is a 68-year-old gentleman, had a history of lupus, found to have neck lymph node on the right side, along with anemia and leg swelling. Found to have some lung coating, some of the inflammation around the tissue that coats the lung, along with lymph node enlargement. And then had a lymph node biopsy from the neck that showed Rosai-Dorfman disease. Third case is a 30-year-old male, had multiple skin lesions of this pink, fleshy appearing skin lesions that were slightly tender, and started on prednisone, which is often the first treatment that these patients receive, had mild improvement, then stopped prednisone after prolonged taper. The lesions got worse. PET scan was done that showed disease involving only the skin, but as you can see, multiple sites. And we'll come back to these cases after the talk is finished. So histiocytic disorders, Rosai-Dorfman falls under this big umbrella of diseases called histiocytic disorders, which are disorders of certain blood cells. And they can be of many, many types. The common ones are Langerhans cell histiocytosis, Erdheim-Chester disease, and Rosai-Dorfman disease. Today, we'll be talking about Rosai-Dorfman disease primarily, but it is important to have an idea about LCH and ECD because Rosai-Dorfman disease or RDD can occur with both of these as well. So let's talk about the clinical and molecular features. The first description of Rosai-Dorfman disease was actually made in 1969, where the disease was described in children with large neck lymph nodes. At that time, the disease was not called as Rosai-Dorfman disease, but sinus histiocytosis with massive lymphadenopathy. In fact, actually, there were a few cases similar to this described 4 years before that by Dr. Destombes, where it was called as um, adenitis with lipid access, just because of how the cells appeared. Eventually, this disease was called as Rosai-Dorfman disease based on the name of the physicians who described these entities. Fast forward many years later, we have learned that Rosai-Dorfman disease does not need to always present with big lymph nodes in the neck, and not just in the children, but it actually in adults especially, it presents with skin lesions as shown here in the images from our clinic. And in our study that we looked at 64 patients for over the last 20 years, we found subcutaneous or skin nodules to be the most common manifestation. Now, the lymph nodes in the neck may be more commonly seen in children, as highlighted by the first case, but most commonly in adults, we have seen that in extranodal, meaning outside of lymph node disease. However, other presentations were common as well. Some tumors were found incidentally, sometimes nasal congestion, cough based on involvement of the nasal pathway or sinuses, and very rarely sort of these B symptoms, meaning fevers, drenching night sweats, weight loss. Average age is about 20 years. In adults, it's about 50 years of age at diagnosis. This graphic highlights all the different organ manifestations of RDD in detail, along with approximate percentages based on our experience and published literature. Most common involvement, as mentioned before, is the skin nodules or skin lesions, but lymph nodes are the second most common involvement with Rosai-Dorfman disease. Other organ system involvement is less common, such as respiratory pathways along the sinuses and the trachea. You can rarely have brain involvement, but most commonly in the form of coating around, a thick coating around the brain, not actually significant brain involvement by itself. Rarely can involve the kidneys, which appearance can be similar to what is seen in Erdheim-Chester disease, or it can form tumors around the kidneys. Another important thing to note is it can involve any bones from head to toe. So it's important when doing scans to get a full body PET scan for staging purposes. A unique aspect of Rosai-Dorfman disease is it can also present in inherited conditions, sometimes in infants who can have Rosai-Dorfman-like lesions, which is called as familial Rosai-Dorfman disease. Other times, Rosai-Dorfman disease can occur with other cancers, such as Hodgkin and non-Hodgkin lymphoma, or with other histiocytic neoplasms. It can also be seen in association with autoimmune conditions, such as lupus and other forms of arthritis and autoimmune hemolytic anemia. Initially, it was thought to be an autoimmune disease because of this very association and the manifestations that can mimic other autoimmune conditions. Again, another graphic showing the various organ involvement. Here is showing sinus involvement in panel B, the skin nodule, bony lesions, this tumor around in the coating of the brain, which can sometimes look like meningioma, can involve the eyes, especially the tissue behind the eyes. Very rarely heart involvement can happen. We have seen plenty cases actually of breast involvement with Rosai-Dorfman disease, much more common than other histiocytosis. Liver involvement can be rare. It can involve rarely testicular tissue in men, where it is found in conjunction with Erdheim-Chester disease. For us to understand what causes Rosai-Dorfman disease, it is very important to take a look at how a normal cell functions. In a normal cell, there are many pathways that control the growth and multiplication of the cells. One such pathway is the MAP kinase pathway, where basically a signal goes from the outside of the cell to the inside of the cell from a series of proteins that are controlled by genes. And they tell the cell to multiply normally and not super rapidly, but generally how the cell function is supposed to occur. However, in Rosai-Dorfman disease, it was found in 2016 that the cells can have these mutations in these genes, which really are telling the cell to grow at a much faster pace, and they are not producing functional proteins. So these cells are not helping us, but they are hurting us when they form these tumors. And so over time, more and more testing was done and found other mutations in the same pathway and beyond. Approximately 50% of the cases now have been found to have one of such mutations. There are the other piece of the pie, which we call is the wild type, meaning we do not understand exactly what is driving those cases. Really, the cause of the mutations is unknown. These mutations have been seen in many other cancers. And it is very important to know what mutation is driving it, because it can help with treatments selection. As mentioned earlier, and as some of you may have experienced, that Rosai-Dorfman disease can occur with other histiocytosis, such as Langerhans histiocytosis, as well as Erdheim-Chester disease. In Erdheim-Chester disease, most commonly we found it to occur in old men where Rosai-Dorfman was found to have testicular involvement and driven by this MAP2K1 mutation. RDD occurring with Langerhans histiocytosis, mostly seen in lymph nodes, where RDD is occupying most of those lymph nodes when looked under microscope, with very few areas that look like LCH. Let's talk about what to do when you suspect Rosai-Dorfman disease. In oncology, we often say tissue is the issue. So there is a need for biopsy. The diagnosis of Rosai-Dorfman disease relies on taking a look at the biopsy of the lesion under the microscope. There are many ways to go about it, depending on what is the location of the lesion. Now, if there is a skin nodule, the dermatologist may be able to do a punch biopsy, shave biopsy, and can get a large sample of tissue. However, if it is an internal organ, such as kidney, you may have to do it through CT guided or ultrasound guided biopsy through a needle. Usually you get a smaller tissue sample, but sometimes we are able to do multiple samples to acquire enough tissue to make a diagnosis and also do genetic testing. Rarely we have to do a surgical biopsy if needle biopsies are not helpful for diagnosis, or we need more tissue for additional testing. And that needs to happen in an ER, but it still is usually an outpatient procedure. This image basically is just highlighting what happens when the pathologist looks under the microscope. And I don't expect you all to, or the goal of this slide is not to learn specifically what tests are positive versus negative, but just making a point that there are several stains. As you see all these markers, the S100, CD68, CD163, OCT2, cyclin D1, a lot of these stains or dyes are done by the pathologist on the biopsy sample after preparing the slides. So it takes some time to arrive at a diagnosis, and sometimes there may not be classic features of Rosai-Dorfman present in a biopsy where additional testing may be needed. Once the diagnosis of RDD is established, it is very important to assess what organs are involved with the disease, which is something similar to what we call as staging in oncology. So it is recommended in the guidelines, actually, that full body PET CT scan, including the lower and upper extremities, meaning head to toe PET scan, should be done. Now, sometimes in children, very young children, it is not feasible to do a PET scan. So other imaging modalities such as MRI, ultrasound, etc., are done. Now, if there are other symptoms such as head or brain involvement concerns, then additional imaging may need to be done, especially an MRI of the brain. If the eye involvement is suspected, then you can do a dedicated MRI of the eye, or if a spinal involvement is suspected, then you do an MRI of the spine. So basically, after doing the initial scan, if there are other areas that are of concern, additional imaging needs to be done. Here are the various lab studies that are recommended for a case of Rosai-Dorfman disease. Other than the basic tests such as complete blood count, inflammatory markers, kidney and liver function, electrolytes, In cases, especially where there is a concern for autoimmune disease, it's important to test for those diseases by certain antibody testing in the blood. We actually did a study recently and we found a high prevalence of autoimmune diseases in people with Rosai-Dorfman disease, to the point that now guidelines may be recommending doing some of the basic antibody tests in every patient at new diagnosis of Rosai-Dorfman disease. Another important point to keep in mind is once you get the tissue biopsy, it is recommended to check for those mutations that we mentioned earlier in the MAPK pathway, and what we call it as next generation sequencing. NGS is a term you may see thrown around quite a bit. Next generation sequencing is just looking at the DNA of the cancer cell. Now, this is not the DNA that you transmit to your children or receive from your parents. This is called somatic, not germline, meaning it is looking at the DNA of those tumor cells. And there are many commercially available assays that are used. So it's important to ask your physician about whether this testing was done. Now, this may not be necessary in every case. If it's a localized disease, then there's no other need for treatment. If it's a clear-cut diagnosis and a surgery or something simple needs to be done. But generally, guidelines do recommend doing that, especially if you are thinking about doing other treatments beyond just a simple procedure. Bone marrow biopsy is generally not recommended in every case of Rosai-Dorfman disease, except when there is a concern for a blood involvement by abnormal blood count. And in infants or young children, if there is a concern for family history of Rosai-Dorfman disease-like illnesses, it's important to test for them and discuss with your doctor about them. So let's talk about the treatment options for Rosai-Dorfman disease. I tend to break the treatment options into two categories. One is targeted therapies, which are newer, and conventional treatments, which have been used over the last few years or decades even. So conventional agents are of different categories. So you could include some immunosuppressants or immunomodulators, such as steroids, prednisone, dexamethasone, methotrexate, and so forth. Chemotherapy, which includes chemotherapy that has been used in other histiocytosis, cladribine, cytarabine, vinblastine, etc. And then rarely other agents such as rituximab, radiation treatment, sirolimus is something that has been used as well. Targeted therapy involves the inhibitors of the MAPK pathway using a MEK inhibitor. Now, this one is important because cobimetinib is the only drug that is approved by the FDA for the treatment of histiocytic neoplasms in adults, such as Rosai-Dorfman disease. But there are other MEK inhibitors available as well, such as trametinib and binimetinib. If one is not able to be tolerated or inaccessible, the other one is perfectly fine to use. So this was the study that got the approval of cobimetinib in all histiocytic neoplasms, including Rosai-Dorfman disease. And this study had a mix of various patients and a handful of patients with Rosai-Dorfman disease, and found nearly 90% response rate, which is excellent response rate, and highlights how important this line of treatment is for cases with RDD. We did a study subsequently just looking at patients with RDD, trying to figure out, are there certain factors that are able to predict whether someone is going to have a response to a MEK inhibitor such as cobimetinib. So we had 16 patients included in the study. We found that the response rate, meaning what percent of people had a shrinkage of the tumor, was close to 60%. When we then looked at patients who we were able to find these mutations, KRAS or MEK mutations in the tumor, the response rate was close to 90%. Where those mutations were not found was nearly 40%. So as you can see, the response may be strongly tied to what mutation is driving the Rosai-Dorfman disease. But at the same time, it is also possible to have a response if there is no mutation found. That may be just due to the way the test was done and it just missed the mutation that may be still there. So it's totally fine to start that treatment even without a mutation. So the optimum treatment approach for Rosai-Dorfman disease is unknown. So there are consensus guidelines out there where the experts sort of come up with a plan, an approach where they all agree on. And this is an algorithm that I tend to use, or I think about treatment of Rosai-Dorfman disease accordingly. Now, if there is a clinical trial available close to you, I would strongly encourage participating in a clinical trial, because that can help with bringing new treatments available, such as cobimetinib for patients with histiocytosis. However, generally, the first question to ask is, are there any symptoms? Is the Rosai-Dorfman causing any symptoms? And the second question is there any critical organ involvement? Meaning, is there any internal organ involvement, such as brain, hearts, kidney, lungs, any of those problems? If none of those are happening and the patient is feeling well, it is okay to have a surveillance approach or observation where we are just watching. We are not saying you don't need to see me again. We are saying, yes, we're going to keep watching you to assess how fast the tumor is growing, but we don't need to jump to treatment necessarily. Now, sometimes there is just a single lesion on the skin or somewhere else where the surgery is done for a biopsy, but that surgery can also be the treatment because that was the only site of disease, which is completely fine, and that could be curable. In that approach is a curative approach, and Rosai-Dorfman disease may not come back. I have to say, though, that we don't have very long-term data on patients with Rosai-Dorfman disease to answer truly what looks like a cure. Now, if there are symptoms or critical organ involvement, and if surgical resection is not possible, or if it's a very large surgery that is needed, in general, the approach is similar, is using either IV drugs or pills. One of those conventional treatments or targeted treatments are totally fine. If a mutation is found on the mutation testing, any MAPK pathway mutation is found, then a MEK inhibitor such as Cotellic or cobimetinib is totally reasonable, but other treatments are also reasonable to use. One point I want to make about steroids is when we looked at our experience with steroids, we found that they work, but they cause a lot of side effects because how long you have to take them. And a lot of patients actually ended up having disease come back regardless after stopping the steroids. So that is something that I myself do not usually prefer as the first line treatment, especially if there is several organ involvement and we found a mutation. But it is still a reasonable approach to consider in case-by-case basis. Once treatment is started, it is very important to monitor how the treatment is working. Is the tumor shrinking? And then also to keep an eye on side effects of the treatment. So generally, we do a PET scan again if the initial disease is active on a PET scan to see if that activity has gone down, which is very encouraging to see. Every few months, we do imaging until we get to the best response. And then you can cut down on how frequently you do the imaging to even a point where you can stop doing the imaging based on how the patient is doing. Alongside that, any side effects from treatment or any anticipated complications from treatment need to be monitored. Along those lines, I wanted to spend a few minutes talking about the side effect profile of these MEK inhibitors, such as Cotellic, which has now been approved by the FDA, and several patients are on these treatments. And these side effects can be just a simple nuisance, but these side effects can be pretty severe as well, that they affect your day-to-day functioning. Some side effects can be managed by reducing the dose, which are dose limiting, where you cannot go up on the dose. Others just preclude you from giving any treatment at all or with the same class of drugs. Common side effects with these agents are a rash, other skin problems, joint pains, fatigue, diarrhea, leg swelling, And sometimes you can have laboratory lab values, basically your blood tests look abnormal. It may not affect your functionality in a major way. The rare side effects to keep in mind, but which are serious, are having problems with the eye or heart. So patients who start cobimetinib or other MEK inhibitors, they often get a retinal exam, specifically looking at effects on the retina, as well as an ultrasound of the heart called as echocardiogram to look at any effects the treatment might have had on the heart function. It's just there's no perfect way to treat with these drugs, but it's just a matter of trial and error. And some side effects may get better with time, but it's always important to discuss with your doctor about the dose that you're on, whether you need to be on a higher dose or lower dose. And sometimes there is a need to talk to an expert if you're not at one of the centers that sees a lot of these patients. So let's come back to the cases that we reviewed earlier. So the first case was this 7-year-old boy. He was found to have a MAP2K2. It's just a type of MEK mutation, RDD, when he saw me. And we recommended to start the patient actually on Kotelic. He had a very nice partial response. Meaning, if you can see here what the PET scan does, you see all these dark spots, and these dark spots have gone down quite a bit. And that's called a partial response because they didn't go away completely. But he was on it for approximately 2 years, and then Kotelic was stopped. And that led to even beyond when I checked on this patient last year, the patient was still in a sustained clinical remission, meaning the patient didn't have any symptoms in the sinuses, no clinical lymph node enlargement, and doing well overall. The second case was this 68-year-old male with lupus and Rosai-Dorfman disease involving the lymph nodes. He received rituximab first, and rituximab led to no response. Then when he saw me, we found a PTEN mutation. Again, talking about the importance of knowing the mutation. And he was started on inhibitor of that mutation, that protein that mutation produces, called sirolimus. And as you can see on the PET scan here, these areas that were marked in red are all of the sites of disease Rosai-Dorfman, and they eventually went away, near complete response to treatment with sirolimus. Third case with this young gentleman with skin involvement with Rosai-Dorfman disease. Actually, this is a case which started on the cobimetinib and did not really have much of a response, but the disease stabilized, meaning it didn't grow any further. Then he was switched to an immunomodulator called as Revlimid or lenalidomide, which is a treatment which is not new for oncology in general, but it's sort of new for use in histiocytosis, especially Rosai-Dorfman disease. However, and this led to slight improvement in the lesion. So if you look at this, for example, this lesion on the thigh, it's less dark now. However, this treatment was too expensive, so couldn't afford it. So we had to switch to something else, an oral methotrexate. But over time, as you can see, these lesions, how they were pink here, they slowly sort of dried out a little bit and became dark in color. Overall, the patient is doing really well. In fact, I followed up with his oncologist a few weeks ago, and he's still doing well on this pill. So just giving you different flavors of disease doesn't mean cobimetinib is going to work for everyone. So there are other treatments that we have to keep in mind. Since histiocytosis or Rosai-Dorfman disease, it involves multiple organ systems of the body and can be very hard to diagnose and treat, I think it is very important to have evaluation by a dedicated histiocytosis team for each case if possible, but if not possible, at least for the complex cases or where the path is not clear. And we have at UAB, I was fortunate to have people who were willing to participate in the care of these patients, and we've launched our histiocytosis program here at UAB, which it makes it much easier. to get evaluations as necessary based on what organ system is affected or what the question is about diagnosis or is it for treatment. We also have a histiocytosis working group that we started back when I was in fellowship at Mayo Clinic, and slowly has now expanded to involve multiple institutions. And we meet once a month to review cases educationally, to discuss complex cases and to help out. If any, that is another avenue for people to ask their doctors to present cases at this meeting if they have any questions or need an additional input. We'll discuss very briefly about our ongoing efforts in histiocytosis, especially pertaining to Rosai-Dorfman disease. As I discussed before, we don't really know what are the long-term outcomes in Rosai-Dorfman disease, especially now that we have all these new treatments. We do know that the prognosis is excellent. In the previous study I mentioned with 64 patients with Rosai-Dorfman disease over the 20-year period, we did not see any case that had where there was death due to Rosai-Dorfman disease. Which is encouraging, but the long-term follow-up was limited in that case, in that study for each of the cases. So we don't know what are really their long-term health problems with Rosai-Dorfman disease. We do think that the short-term prognosis is excellent. The long-term is likely going to be excellent as well. But the patients, when they have multiple organ involvement, they get multiple treatment types, there is a risk to develop long-term other health problems from treatments or from Rosai-Dorfman disease as well. Other question that comes up is how long to follow up in the clinic. Should I see the oncologist after 5 years or after 2 years, or should I stop seeing them? Should I see a general practitioner after that? We don't know, because we really don't know what are the long-term health problems. Those are the kinds of questions we want to answer. So to answer this, we launched the histiocytic disorder follow-up study, or the survivor study, back in 22. And this study is really a very large national study of people with various histiocytic disorders, including Rosai-Dorfman disease, trying to answer the question of health problems, hospitalizations, clinic visits, mortality, and what are the risk factors that lead to any of these health complications. This study is in partnership with the Histiocytosis Association and ECD Global Alliance. To participate in the study, really, you need to have any diagnosis of histiocytic disorder. And this is our study phone number or email if anyone is interested. They just need to, you don't have to travel to participate in this study. So it just requires completing a survey and also providing access to health records to confirm the diagnosis and other complications. And that survey can be taken from home. And we also give a small gift card as a token of appreciation for the time spent. Right now, this study is only for English-speaking patients. We are looking to expand to Spanish in the future as well. Of note, patients who passed away from the disease, their family members can actually participate in the study as well. So please reach out to us if you are interested in this study. So takeaway suggestions. I think the most important thing is Rosai-Dorfman disease affects everyone differently. So no two people with Rosai-Dorfman disease may be alike. We know much more about RDD now than we did, I think, 10 years ago. Most importantly, to know that common involvement is usually the skin, followed by lymph nodes. It's very important to know what parts of your body are involved. Generally recommended to get a full body PET scan. It's also important to know the gene mutations that are driving the Rosai-Dorfman disease by NGS testing. Given the strong association with other cancers and autoimmune conditions, it's important to make sure that something else is not going on. Prognosis is generally excellent. Not everybody needs treatment at the time of diagnosis. You can be watched closely to assess the tempo of the disease. There are cases where Rosai-Dorfman disease can actually shrink on its own as well. especially lymph nodes in the skin. So it's okay to not treat right away. If something doesn't fit well, it's important to get a second opinion based on what options are available through your insurance provider. Sometimes you can do a telemedicine visit, although just making sure that you have, if things are not going right, to getting an opinion is totally reasonable, and advocating for yourself. Finally, none of this knowledge that we have today would be available if patients did not participate in research and advocacy. So we strongly recommend to participate in registries that are available through the Histio Association, ECD Global Alliance, and even consider participating in our follow-up study. With that, I will end. I'm very thankful to the patients and families who participate in our studies, to our collaborators, mentors, at UAB, outside, our partners, patient organizations, and our patient advocacy partners and our funders. And thank you all for your attention and time. I will take questions now. This is our team, and this is our study line phone number, as well as our study email address if you feel like you want to know more about the study. Okay, so are there any questions, or is it all clear as mud? Let's see.
I'm seeing some here in the chat.
Okay. If you are not detected with the mutation, can you still get inhibitors treatment? Yes. Like I showed the data, we have seen responses in cases even without mutation. That does not necessarily mean that there is no mutation. That may mean that just we could not detect the mutation with the available tests. Sometimes actually, when sometimes we see the response is so quick, just in a couple of days, within a week, that it's almost like there is a mutation, but we missed it. We go to the raw data, which your doctor can do. We can ask the company, and there is usually a hidden mutation there that they did not report because it was low level mutation, so they didn't feel like reporting it. The next question is, with other autoimmune disorders and cancers, do they typically present at the same time at our? Yeah, very important question. So we found that nearly half, or a little over half, patients with RDD had the autoimmune disease happen after the diagnosis of RDD. So that also means that nearly half had it before. So I think it's partly a matter of under recognition. And these numbers are talking about patients, who were not getting regular screening for autoimmune disease. So this may be an underestimation. So anytime things change, it's important to get evaluation. If the clinical history doesn't fit, if something else is going on, it's important to look for these disorders. And of course, the ultimate question is RDD considered a cancer? That's a loaded question, because the word cancer by itself tends to give us anxiety. At the same time, it is important to answer this question. One thing that happened in 22 was that the World Health Organization recognized Rosai-Dorfman disease in its classification of blood cancers. So in simplistic terms, in a yes or no, yes, RDD is a cancer because at least half of these cases have those cancer-causing mutations. But to some others, the word cancer can mean something that is serious in terms of can it cause someone to die, or can it be rapidly growing, such as a leukemia would. In that case, I would say it's more like a slow-growing tumor. So it has features of this inflammatory disease and features of cancer at the same time. So it need not cause the level of anxiety a more aggressive tumor does, but at the same time, the designation of it as a cancer allows you to get all the testing that is needed and to get all benefits that you can that come out of recognition of something as a cancer, including the NCCN guidelines, the National Comprehensive Cancer Center guidelines, which have now enabled doing all this testing and getting drugs as you would for a cancer very easily without insurances saying no to you. Next question is, please provide more information about the working group and how providers can access that. So it's not a, the best way to do it is to reach out to us through your physician. And we meet every second Thursday at noon Central Time to review cases. Now, that is more for it's since we have not seen all of the patients or all the cases that are presented, so it is more educational. But a lot of physicians who present their cases, they find that they derive benefit from discussing. So the best way is to reach out to me or to our other collaborators at Mayo Clinic or Moffitt or University of Michigan from your oncologist who can present the case, and then we can go from there. Next is, I had extra nodal in the bone, can it reappear as nodal? Yeah, that's a very important question, and that's really what I was trying to get at, as that we don't know long-term data for this disease. Generally speaking, if you ask me my experience and based on our published data, we don't usually see extranodal becoming nodal in the future. And I sort of, this distinction between extranodal and nodal does not really affect management that much. The biggest question again is that question: is it affecting your internal organs, and do you need treatment beyond? Do you need any pills or IV treatment? And that is the most important question. But I have not seen cases that present with extranodal and few years down the road now have lymph nodes. But it can happen. It may happen, but I just don't know the answer to that. And that's why it's important to do the long-term studies. Next question is, Cotellic is effective on MAP2K1 and RAS-A2. I don't know anything about the RAS-A2 mutation, but yes, Cotellic is effective for MAP2K1. It is effective for KRAS mutations. That's the one that is seen in Rosai-Dorfman disease commonly. What you have never been in remission, 20 plus year, tried everything. What should be tried next? Yeah, I mean, that's a medical question. I would have to know more about your case. But as the treatment options that I presented in the table, conventional treatments, I think that's important. And the other important thing is to make sure the new biopsy is done and to get genetic testing on the biopsy, because sometimes that can help find targets that you can target by some drugs that are available for other types of diseases. That's the first thing to do. But then there are other treatments options that can be utilized as well. What kind of specific tests are done for the gene mutation? Yeah, so it's called next generation sequencing, or NGS, and you can ask your doctor about it. They are commercially available. It's ideally recommended to broad test looking at all the genes that cause cancer, because it's more efficient rather than looking after one or two genes, because you're using up the sample quickly, and that sample is precious. So it's very important to do these tests on the tissue in the most efficient manner. This is a question about someone having RDD. Sons are being worked up for RDD, and there is a connection with ALPS. Familial gene mutation is an absolute thing, or is still possible without it? Yeah, so familial cases can occur generally in any cancer without finding an actual germline mutation. So that's a very valid point. But that being said, at the same time, it's important to get a workup done to make sure you don't have anything that is well known to be associated with RDD by genetic testing. Next is, my child often complains of joint pain. Scans were done, but only mild swelling. I'm hearing for patients that oftentimes they're dealing with chronic joint pain, also clear scans. Yeah, so right now we don't have answers to this question, and that's why we are doing this study. We are really trying to figure out what are the symptoms of patients with RDD. In LCH, now we have seen that NECD, that patient can have clear scans, but they still are miserable due to pain, fatigue, and so forth. We don't know that much information about RDD yet, but it is potentially possible that it's related to the treatments or the RDD itself. And sometimes, additional supportive care or symptom management is very important, because there's no point in having a disease in remission if you have a lot of symptoms as a long-term effect or a late effect.
Gaurav?
Yes.
Can you hear me?
Yes.
Hi. First of all, thank you very much for your presentation. It was wonderful, and it's really incredible to have people like you presenting to us, to patients, to families, to associations, and have the possibility to understand much more about this disease. One of the things that you are researching on is the follow-up on patients. Maybe it's not really directed only to RDD, to Rosai-Dorfman, but you have some specific and important interest on what's the long living of these patients and how to follow them up and what's their well-being, right? So I would like to, maybe if you can, in 5 seconds, 10 seconds, also tell us about those studies and how we can also, or how can patients participate on those.
Yeah, so I had a couple of slides. So basically, most important question we are trying to answer is what happens after the diagnosis of histiocytosis? What are really the health problems, the symptoms, and including pain, fatigue, and chronic health conditions that occur in someone after diagnosis of, for example, Rosai-Dorfman disease. And that is really a big unmet need right now, because as you can see from some of the questions that have been asked, and then trying to figure out what are the causes or what are the associated factors for those health problems. So that is what the study is trying to look at. And then even further trying to figure out if there are complications such as death, what is this happening because of? Because really we want to prevent that, right? Is it happening because of a second cancer? Is it happening because of a treatment complication? Or is it happening because of histiocytosis? And really, so we are trying to address that. So we have a study email, histio@uabmc.edu. And so, anybody can feel free to email us. We have actually enrolled international folks on it too. For now, we are limited though because of the English speaking requirement, but we are looking to expand that to other languages in the near future.
One of the things that in line what you are saying, all those symptoms that you have described that are it's what I hear from patients when they talk to us, the associations and so on. One of the aspects that they encounter is that they don't have such experts in this disease as you, that you have seen so many cases. So what is the recommendations also for them? Means to try them to describe as much as they can to their physicians in order to understand that this is something related to something else, because not all of them can reach you, and they try to, and you answer very, very fast. And I am aware that you do a lot of also international things, and as you said, there is this forum too, but not all of the doctors are able to really participate, also for language barriers that we are not gapping as with this webinar, right? So what's the recommendations for them? Because sometimes they hear about these inhibitors treatments, but their doctors are not really aware of them, or they can really start with them without really having a mutation, diagnosed in between.
Yeah, that's a very important question. I don't know if I have an easy answer for that. I wish I could help everyone directly. If I could go everywhere and help everyone. But, I do get emails. I try my best.
Let's mention that you will be here in Barcelona the 26th of May and 27th of May, participating in an Ergenchester encounter that will be here in Barcelona happening. So you will come to Europe and see patients and families in abroad, let's say.
Yes, I'm looking forward to that visit. Thank you, Fernando, and looking forward to visiting a wonderful country and city. The I think the biggest thing I would say is knowledge is power. Um, and knowing everything about your disease is very important because, even now, I've been seeing histiocytosis for 8 years or so now. And like every time, every patient teaches me new things. And, knowing about your disease, knowing about the disease in general, and listening to your body is very important. And I cannot emphasize enough the power of self advocacy. So you got to, and sometimes my patients would go back to their doctors who initially saw them and would provide update or education about their case progress after they were initially seen to them to provide education. So really it's a collective, all of you here are asking all these questions, such a powerful community. And I think doing things like this is very important. Sharing this information, sharing these links with your doctors, again, very important. And that's the best you can do. And if, the most important thing is for your doctor to listen to you. That's the first thing. Everybody needs that, and not to brush away your concerns. And if that not doesn't work out, you should feel free to get another opinion. And especially in 2025, I think there are many ways. What other thing we have tried is to, and with ECDGA and HA, and Fernando, you probably also maintain a database or registry of providers who are experts in these diseases. And by expert, it doesn't have to be that they have seen 50 or 100 cases, but at least having interest in the disease, even if they have seen a handful of cases. And ideally, it would be nice to have one such center for, let's say, 100-mile radius or something like that, so people can go to those centers. And so I think beyond that, I don't have any other bright ideas. Our current system unfortunately does not allow remote consultation. So that would have been such an ideal system. In the US, we have to look at our license and so forth. So if anybody can fly and see me here, that's fine. But if I provide a medical opinion to a different country, that is not allowed generally. Yeah.
Yeah, I think that this platform again gives us the possibility to connect with many and try to bridge that the gap that we have with the language barriers. So yeah, hopefully again you can participate in forums for Latin American doctors and they can answer you and you can give live feedback and so on. So I think that also from the associations we have seen that need was to be covered and we are trying to get that as well. And also linked to that, I wanted to share that maybe the patients that are here already know, but both the ECD the Global Alliance, the Ergenchester Global Alliance, does have groups, support groups from peers-to-peers group as well, not only from the medical side, but as you were saying, right, to try to also meet other patients and know what they are feeling. So there are both the possibility to do it in the US and also with our groups, the support groups that include both ECD patients and well, as Peter is showing now, I believe from behind the scenes. So yeah, and also some important dates that there are. And again, try to emphasize that you will be here in Europe in May, 26th and 27th of May here in Barcelona, to also talk about the adult patients with ECD. And there will be here also Eli Diamond and Julian Roche, as I understood. So there will be plenty for patients to really get in touch with you, in contact with you, and well, share with you their feelings, let's say. So thank you very much.
Yeah, no, thank you for having me. I think we're at the top of the hour. I know there were some questions that I could not address, but I'm happy to address anything specific later on via email from you guys if there is something that is really outstanding.
Absolutely. And as well, there's going to be a post webinar survey sent to you guys in about 5 minutes or so. And so after you receive that, one of the questions is, are there any questions that weren't answered? And you can forward along some of your questions that you hadn't got a chance to have answered here, and we'll try to pass it on to Dr. Goyal. Just make sure your email's on there, and we'll try to follow up. But other than that, as Fernando was saying, there's some resources from us on the ECDGA and OR association that we have, and I'm just going to quickly scan through them here as we don't have a lot of time left. So these are the ones from us at the Histiocytosis Association: disease information, educational videos, pamphlets, peer-to-peer meetings. And here are the ones from the Canadian Association. And as mentioned, here is the 10th annual ECD patient family gathering that Fernando mentioned, taking place in Barcelona on the 26th of May. And you can register there. That QR code, or reach out to Belinda Cobb at the QR code below. And then here are the resources from the OR Association, that a lot of which were mentioned already, but just so you could look at all the rest of them. And again, there's going to be a brief survey sent to you following this meeting, and I just thank you all for being here, and Dr. Goyal for joining us. Hope you all have a great day.
Bye, everyone. Thank you for being here.